Hello, welcome to another episode of Move It or Lose It. And today, I'm like I always say, but one of our favorite doctors in the world, who I wish desperately was my neurologist, Dr. Brandon Beaber. We are so excited to have you with us today.
Thank you for having me, Kathy, and Happy New Year.
Happy New Year. Hope you guys had a great New Year. Did you have some relaxing time?
We did, although we went to sleep very early. The only reason I stayed up to midnight was to film a YouTube video, which I published today, the day that we're filming this, about the multiple sclerosis quiz. That was the only reason I was up to midnight. I missed the countdown entirely.
You did? Oh,
yes,
no.
Although I did better than my wife, who fell asleep at about 9 p.m. So I outshined her at least.
I understand that. I actually rallied and then came downstairs with cheers, then it was already past midnight. I'm like, I did it for nothing. So I love the video. If you guys have not seen it, well, it'll be too late now, but go back and take the test, because I thought it was great. I did it and I was like, I never felt so smart. So I would say definitely take it. It's really good. You made it fun, and I thought it was great. So go for it, take it.
You definitely have the advantage over most people, given that you're doing this all the time.
Doing it all the time, and I've had it for quite a few years, so I better know this. So thank you again for doing this. I've got my questions as always, but I really just tried to take what the listeners have asked me to ask you, because and I know that you are the number one doctor that they ask for with my guests, my Move It or Lose It guests. They want to, what doctor do you want to hear from? Dr. Beaber. So you can feel very good about that. So one of the questions that people have had for you is our questions. Let's go back to that. So I want to talk to you about the efficacy, some of the drugs. Let's go into that first. So some of the things that you and I talked about were some of the concerns with a lot of the groups that I work with, and their confusion with, okay, I've been diagnosed with relapsing remitting. I'm concerned because my best friend Susie, who was diagnosed with relapsing remitting, was put on Covaxin, and I was diagnosed with the same, and they're putting me on Ocrevus or something, something similar to that. Why is there such a huge difference?
Yeah, I think what you're getting at is, how do we choose what medication someone should be on, or how should you choose? And This is an ongoing debate in the field, and it's still very controversial. And of course, everyone has their own personal preference and risk tolerance. And from the perspective of a neurologist, we have our own biases, the way we've trained, our experiences in medicine, our own views about taking risks with pharmaceuticals. The inherent problem is there's sort of a correlation between the efficacy of multiple sclerosis disease modifying therapies and safety. What we'd like is to have a drug that's a once-a-day pill and it's 100% effective with no significant risk, but we just don't have that. We have drugs that are very safe, such as glatiramer acetate, the injection Copaxone, or Glatopa, very low risk, no significant risk of weakening the immune system. But the results in clinical trials show a modest efficacy, and some people taking it just don't do that well. They could still have relapses or new MRI lesions despite taking it. We have stronger drugs like Ocrevus or Tuximab, Kesimpta, now, ublituximab, newly FDA approved just a few days ago, Lentrada, hematopoietic stem cell transplant, cladribine, but all of these drugs have a significant risk of weakening the immune system. So let's say you're a 25-year-old with newly diagnosed MS, you just had optic neuritis, your vision went back to 20/20, you're feeling great, you're a CEO of your own company running marathons. Why should you take the risk of taking a significant immunosuppressant? So the sort of old school view is the idea of escalation therapy, which is start slow, take something like one of the injectables, the beta interferons or glatiramer acetate, or maybe one of the pills for MS, Tecfidera, Aubagio, and then maybe if it doesn't work out, you can escalate to a stronger agent. But some people believe we should be doing the opposite, which is just start with the stronger drug, even in a young, healthy person with low disability with relapsing MS. And if you had asked neurologists 15 years ago, virtually all of them would favor escalation therapy. But there's sort of increasing evidence that it may be better to start with the stronger drugs up front. And the reason is simply that this is all about prevention of disability. These drugs don't enter the nervous system, generally speaking. They don't grow nerve tissue. They only prevent inflammation. And so if we see someone who's young, relatively low lesion burden, low disability, and prevent new inflammation, maybe this will have profound benefits 20 years later. And there's actually a lot of evidence for this. One would be observational studies. If you kind of look at people who have taken stronger drugs, say Limtrada or Orcovis, and compare those people to those who have taken weaker drugs like Tecfidera or glatiramer acetate, on the average, people taking stronger drugs tend to do better. And there are various observational studies in different countries showing this. The problem with that method of research is it's potentially biased. It's not random who goes on what drug. Maybe people who are more well-educated, maybe people who do more multiple sclerosis research, maybe people who are healthier in other ways are more likely to choose the stronger medications, or maybe they have less other medical conditions, so they're more willing to tolerate the side effects. So that's not necessarily 100% accurate. However, there's some more evidence. For instance, in the randomized trials for the drug Tysabri, which is the once-a-month infusion, they actually had a long-term follow-up of people who were randomized to Tysabri versus people who were randomized to Avonex or randomized to placebo, depending on the trial. This is called the Strata dataset. And it ended, I think, around 2014, because after many, many years, you get less and less follow-up, and then it starts losing its meaning. But what they were able to demonstrate is long after the clinical trial ended. In other words, you had 2 years of Tysabri versus 2 years of something else, either placebo or Avonex. And so you're really only looking at a 2-year difference in treatment. Even many years later, there was still a difference in disability. So starting on a stronger drug now seems to make a difference many years later.
Yeah.
Now, the best way to answer this question would actually be to do a randomized trial. And there are actually 2 ongoing randomized trials.
I was going to ask you.
Yeah, one is called the Treat MS trial. The other is called the Deliver MS trial. They've been going on for a while. I'm not exactly sure how close they are to completion, but probably fairly soon. But I can tell you my opinion right now is that very likely these studies are going to show that early high efficacy therapy is better on the average. Everyone's different. I see some people with very mild disease. Maybe they had optic neuritis and just a few brain lesions, nothing in the spine. Should that person take Limtrada or hematopoietic stem cell transplant? Well, maybe not. But I would say for the typical person with MS, with relapsing MS, I'm going to at least offer them high efficacy therapy right away. That's my personal opinion.
Yeah. No, I agree with that. And the doctor that I think you and I have talked about this before, that I had years ago, that has since 6 years ago passed, that was the way he did things as well. I started with Avonex with the very first neurologist that I ever had. He was a neurologist that covered everything. So his MS knowledge wasn't as high as the doctor that I had switched to. However, he started me with Avonex. And so it didn't keep me from relapsing. I had 3 children at that time. And so the doctor that I switched to, Dr. Howard Rossman, was just he was waiting. Tysabri was right on. I got into a little bit of the study and then the trial, and then went on to that and did wonderful on it. So I agree with you. And of course, we're all different. There's no 2 people with MS that are the same. But for me, I did very well. I was able to have a pretty much normal life, was able to run half marathons, and he threatened severely me all the time with other Boston people who had done a full marathon, and would constantly I'm like, how did they know I ran? They're right next to me. He would do that on purpose, things like that. And they would tell me like, ooh, that's a pretty tough one to do a full, because you really can't keep your temperature down. And I had a pretty bad relapse, and I'd see him over. I'm like, how did this person get next to me? But I did appreciate the fact that there is a limit as to what we can do. And so I always kept very active, but half marathons was my limit. And so I do tend to agree with you that starting in, that was like, so I'm going to say full on Tysabri was 2003. I might be a year off.
Well, that would be when the clinical trial started. It was
Okay.
approved in 2005.
2005. Okay. So that's when I was fully on it. And then I just did great on it. And so I do truly believe in that. And I wonder that with the studies and stuff, how do you believe in, is there, now I'm going to ask you a question just on your own belief in this. Do you think that it stems from not only where a patient comes from as far as when they come in with their coming to a neurologist with their symptoms, but do you think a lot of times it comes from their ethnicity as well?
Well, I think a lot of it has to do with symptoms. People who have had a worse history of MS are kind of more eager to go on stronger drugs and more willing to take risks. Imagine if you had transverse myelitis with paralysis and you were in a wheelchair for 6 months and, you're recovering, pretty much whatever side effects I talk to you about will go right over your head. You'll be like, I don't care. I just want the strongest drug. Whereas someone who had maybe a little bit of numbness that went away in 4 days spontaneously isn't going to be quite as concerned. In terms of ethnicity, generally speaking in medicine, there seems to be a bias where, certain ethnicities tend to receive less treatment. They tend to be diagnosed later, like African Americans and Hispanics and Native Americans in the United States. And it's probably due to a lot of different factors. One of them could certainly be the bias of their doctors. There's another problem with a lot of underrepresentation in clinical trials of certain ethnicities. In the recent study for Briumvi, ublituximab, which is a B-cell depleter similar to Ocrevus that was just FDA approved.
What is the name of that again? Can you say that again?
Ublituximab or Briumvi.
Can you spell
it? Off the top of my head, ublituximab, I believe.
Nice. Okay.
And I was looking at the clinical trials results because I was going to make a video on it. And it was something like 97% Caucasian in that study.
Okay.
Now, generally speaking, I don't think there's going to be a huge difference in efficacy and safety in these medications in different ethnicities, but you never know. With the drug Ocrevus, they actually did have a very good study specifically in African Americans. But for most drugs and for most conditions in general, not just MS, there's a lot of underrepresentation of certain ethnicities in clinical trials.
Yeah, for sure. I definitely see that. And I think that you knew that I've done a podcast on that. I specifically just did with Black people, and I just did that specifically on the drug companies and just not getting the quality healthcare that they should, and the iniquities in that. And I just wanted to really have a really good conversation, and we did, and it ended at a very positive note and a very loving note, and where do we go from here and how to move forward. And so I really appreciate you talking about that with me. And I do believe, like you do, that we go harder and not softer and wait for it to get worse and then say, guess we better go stronger now. So I don't like that idea. But so I do believe now, as far as like the Tecfidera and stuff like that, I often hear patients that will be on something like Ocrevus or something like that, or Tysabri, and then a neurologist will come to them and say, I know you've been on this, you don't like it, not that it hasn't kept you from relapsing, but what do you think about going now to Tecfidera or something like that, a pill? So that often confuses me, especially when it's a client or somebody coming to me and telling me that. I obviously can't speak for the doctor, but it often confuses me because I think, isn't that going the opposite way, the opposite direction?
So you're talking about the idea of de-escalation.
Yes.
So generally speaking, there's a lot of observational evidence that the difference of high efficacy therapy and low efficacy therapy is likely to be greatest in people with relapsing MS and people who are younger, essentially people who have the highest risk of relapses and making new MRI lesions. And there's this idea that, hey, maybe if you get older, particularly if you've been stable for a period of time, maybe you've had side effects from other medications, maybe you don't need as strong of a medication. And that is something that I do believe in. I have some patients who have been on immunosuppressants and maybe they got bad COVID or they had a bad UTI and were hospitalized and their MS is kind of stable. And I say, hey, maybe the risk to benefit ratio has shifted a little bit. And I think that's very reasonable. There's not a lot of evidence for that, but I do think sometimes that's a practical approach. Some people just aren't good candidates for immunosuppressants, and some people just don't want to take them. One thing I should have stressed earlier is, when I say early high efficacy therapy is better, I mean that as a statistical average over a large group of people. Individually, there's going to be a lot of variation. Sure. I saw a patient earlier this morning who takes the drug Avonex, and she had multiple relapses taking Avonex and multiple gadolinium-enhancing lesions. And I told her, look, I would advise you take a stronger medication. And I gave her some options, and she reviewed it, and she was very uncomfortable with it. And she ended up just staying on Avonex. And I followed her for several years. And she's actually very stable. And this is someone in their mid 50s who has very low amount of disability, despite taking a medication that may be doing nothing for her. And so there's a lot of individual variation.
Sure.
And some people just aren't comfortable taking immunosuppressants. And, I may give advice, but people may just say, I want to do something else, which is reasonable. I mean, these drugs have side effects, and I've been burned many times.
Sure, absolutely. I'm sure. And I can't imagine as the neurologist, that's nerve-wracking because you may want them to do something, they may choose to do something else, and it can go one way or the other. So I'm sure I would not want to be in your shoes. Let's put it that way. So I'm sure that would be a bit difficult. So thank you for answering that. I hope that and again, if you have more questions, you can always email me and I will bother Dr. Beaber again with these. So now moving from there, I wanted to ask you, I hit you up yesterday with some questions about, I was hearing a lot about M14 and what is this? People were saying, this is something you really need to know about. This is something you should know, it's going to be okay for you to take. You should probably think about taking this. Help us listeners who have never know nothing about this. What in the world is it?
Well, I'm glad you sent me an email about that, because otherwise you definitely would have caught me off guard. So this is a study for the drug elezanumab. And, I've heard about it quite a bit. In fact, like one popular content creator, Misguided Bits on Twitter and YouTube, actually entered the clinical trial for this drug, and she reported her experiences taking it and everything. So this drug is an antibody, a monoclonal antibody against RGMA, which stands for repulsive guidance molecule A, which is a protein that's involved in nerve sprouting. And it's thought to have a lot of significance in the development of the nervous system, but this is actually an inhibitor. So it blocks nerve sprouting. And this probably makes sense from the perspective of growing a central nervous system and then knowing when to stop growing so you're not creating a lot of unnecessary connections. But the thing is that humans don't really have great mechanisms for sprouting new axons within the central nervous system in the setting of injury. We simply have not evolved the ability to do that sufficiently. So the idea is maybe if we block this inhibitory signal in an area of injury, we can get some nerve regeneration. So that's the theory here. It's not an anti-inflammatory, it's sort of a regenerative therapy. And there was a successful phase 1 study that suggests it does get to the central nervous system. It seems to be relatively safe. They were able to look at some cerebrospinal fluid biomarkers. It may even have slight inflammatory or anti-inflammatory effects. And so they moved forward with a phase 2 study, which is actually a randomized controlled trial. And it wasn't a big trial, but they were hoping to show some signs of benefit in people getting it versus placebo in people with multiple sclerosis. And this is the M14 study that you're talking about. And, I could not find an actual publication. I can send you the link to the clinicaltrials.gov site just so people can see the details of the study.
Sure.
But the results were posted on social media and were presented at multiple sclerosis conferences like ECTRIMS. And basically, unfortunately, the drug did not show any benefit to people with MS. And they looked at things like time 25-foot walk, how far you could walk, the 9-hole peg test, which is sort of a measure of
Sure.
hand coordination, and EDSS, Expanded Disability Status Scale, sort of an overall measure of disability. And unfortunately, there were no differences. So I don't know if they're not going to pursue further research on this drug or if they are in a different way. It's actually being studied in some other diseases like spinal cord injury or stroke, but right now it doesn't look like it's going to be an MS drug.
Okay. Now I did hear some things about like people that were having like severe drop foot. Now that they were taking that and it was helping drop foot. Have you heard anything like that?
Well, I know Misguided Bits said she, saw some possible benefits, subjectively. But when they did the statistical analysis, using these tests, they weren't able to find anything. So unfortunately, if it helps, they weren't able to prove it.
Okay. Okay, good. Thank you for answering that. So again, we'll just keep looking, and if we'll have at the bottom of the show notes the link to that study.
Yeah, I think it's important to know that I admire people who enter clinical trials. It's very important. It's also very attractive to get a new treatment that's not available yet, but you do have to know that not all of them pan out. Some of them end up being unproven or frankly ineffective. This wasn't a dangerous treatment. It seemed to be safe. It just wasn't clear that it did anything beneficial.
Right. Okay. Good to know. Thank you for that. And then the other one that I know that we did touch on during the webinar. Thank you again for doing that. That was really something that I deeply appreciated. So did so many of the listeners. You got many compliments for that, and really appreciated that. And of course, one of my favorite women in the world, Jen Powell, who's also one of your patients, just really loved it. And I think she saw you that day that you were with me, and she just really enjoyed the webinar and really enjoyed having you there. So thank you again for that. But I know that we touched on this, so if you could go through it again and help us with a little bit of light on that. Can we talk a little bit more about I'm going to say it wrong, the pineal gland, and the thought to be common, beginning again the calcification of that, and how does that affect multiple sclerosis?
Yeah, I presume this question came from maybe someone who saw their MRI report and the radiologist noted that. And so the pineal gland produces melatonin. It's involved in initiation of sleep. And, as people become older, it can become calcified, and we can see that very easily on CAT scans and MRI scans. But it's very common in the general population. It's a well-known benign finding. It's nothing serious, not specifically associated with MS in any way, as far as I know. Since you sent it to me, I looked into it, and I found one article that maybe people with MS produce slightly less melatonin on average and have slightly less calcification of the pineal gland, but I'm not aware of it having any real significance.
Okay. So as far as for you, you're not seeing that's really, that really correlates.
Yeah. If someone asked me about that, I would say this is just a benign finding. It's not specifically related to MS.
Okay.
It's not like the calcification is caused by MS. This is just something that happens to the pineal gland with aging. Right.
And so when that does happen, is there any effect in our bodies that's different from?
Well, this study found like less melatonin, production. Maybe that is part of the reason that people with MS have more insomnia and more sleep problems. Yeah. But I don't think that's necessarily due to anything we see on the scans.
Right. No, that makes sense. So now shifting a little bit, what are the things now we're already in 2023, which is astounding to me. Every year I get older, I'm like, where'd that year go? So what are you finding? What are you most excited about in this year or the next 2 years, let's say, in things moving along with multiple sclerosis that you're finding that are coming up?
Well, the treat MS and deliver MS studies, I certainly like to see the results, although I feel I know what the results are going to be in advance. In terms of new products, I would say I'm most interested in two major classes of medications. One is the ATA 188 study, which is an immunotherapy against Epstein-Barr virus. And there's an ongoing study called the EMBOLD study, which is a randomized trial treatment versus placebo in progressive MS. I think that's a really new, innovative treatment like nothing we've ever seen before. I don't know for sure it will actually work in multiple sclerosis, but if it did, it would be truly great and maybe offer an effective treatment to people who aren't good candidates for immunosuppressive drugs. And it has implications for other Epstein-Barr virus-related diseases like lymphoproliferative disorder after transplant or Epstein-Barr virus-related cancers such as Burkitt's lymphoma. Now, we probably won't get a result by the end of 2023, but maybe we'll get some preliminary interim result. I don't know.
Yeah.
The other class of medications I'm really interested in is the Bruton's tyrosine kinase inhibitors. These are medications that are different from drugs such as Ocrevus, rituximab, and Kesimpta, in that they don't kill the B cells, but they influence the activity of the B cells.
Okay.
And so they're probably safer in older people with progressive MS. They're probably less likely to cause infections.
Okay.
And, one thing about progressive MS is there's some evidence that some of the progression may have nothing to do with these types of cells, the B and T cells, the lymphocytes. They may actually have to do with a slow sort of smoldering inflammation invisible on conventional MRI within the central nervous system. And so some people, they have this frustration where their doctor is telling them your MRI looks stable, but they just know they're slightly worse over the years. It may be due to a different type of inflammation by the innate immune system, such as the microglia and macrophages within the central nervous system. There's evidence that these drugs have effects on those cells, and maybe they'll even be more beneficial despite being less immunosuppressants. Some examples of these drugs include tolobrutinib and evobrutinib. Do they work or not? Well, hopefully we're close to finding out. Maybe we'll find out at some point in 2023.
Yeah, that would be great. And a lot of my clients are in secondary progressive. And so they get that frustration that what is there for me? And it's frustrating when there isn't a lot. And, again, I'm always trying to challenge them with movement and food, what's being put in. And garbage in, garbage out. It's are we eating, fast food daily? What are we putting in our bodies? So those kind of things. Talk to me a little bit about, we've heard a lot last year about smoldering. And so I get a lot of questions about what does this mean? What's happening in my brain? I think some of it, I want to say the beginning of what I heard was when doctors were doing autopsies, and they were finding activity underneath. Am I correct? Or am I mixing this? Am I mixing studies together? That could happen. I don't know.
Well, the general phenomenon that we see, the sort of clinical phenomenon, is that people often have progression related to pre-existing deficits. So let's say someone has transverse myelitis and they have a lesion on the right side of their cervical spine and they have weakness and numbness on the right side, but maybe they recover and they're doing pretty well and just have a little bit of residual numbness. Let's say that person is a 30-year-old newly diagnosed with MS. Sometimes, unfortunately, 30 years later, now the person is 60 years old, they may be on disease modifying therapy. They may be stable in terms of no new relapses or no new MRI lesions, but they're getting worse. They're noticing more weakness and numbness on the right side. And, even though there isn't a very strong correlation between lesions and disability, there is definitely this phenomenon where we see that people tend to have progression, a slow, insidious worsening in areas of prior central nervous system injury. Even in people with primary progressive multiple sclerosis, sometimes the disability correlates very well with what we see on MRI, even if they didn't have a known relapse associated with that lesion. So what is happening? Obviously, there's something happening within that lesion that is causing function to get worse. Well, there are a lot of different hypotheses. One could be that the damage to the myelin sort of predisposes the nervous system to accelerated aging later on. Maybe a young, healthy nervous system is able to compensate for that injury, get information through those nerve fibers. but maybe later on there's an energy failure of the cells. The mitochondria are not functioning as well. This is the idea of Minding My Mitochondria, the book by Dr. Terry Walls. And there's some evidence for this idea. Maybe there's some degeneration. Maybe the initial disease is more inflammatory, and later on it's more of a degenerative process, kind of similar to Parkinson's disease or Alzheimer's disease, where you're just losing nerve fibers. And we don't really have any drugs that prevent degeneration, even if we stop the inflammation. So those would be the sort of more pessimistic views that this is going to be harder to treat. But the more optimistic view is it's still an inflammatory disease. It's just the inflammation is of a different type that's behind a closed blood-brain barrier. So if I give you Limtrada and I kill your lymphocytes in your blood and your bone marrow, it doesn't matter, because those microglia and those macrophages are already in your spinal cord. They're sitting there. The drug doesn't get there. It doesn't act on those cells anyway. But maybe if we find this new target, we can intervene on it. So that's sort of the optimistic view, that progressive multiple sclerosis is still an inflammatory disease. How do we know that? Well, we know based on autopsy studies that we can see those cells within lesions that seem to have some activity. And more recently, on certain types of multimodal imaging, very specialized PET scans, we can see signs of this innate immune system inflammation. Now, obviously, an autopsy is not going to help, someone right now. And, frankly, even these multimodal imaging studies aren't going to actually help an individual person with MS, but they'll help us understand that this drug could be effective. But, just like with the elezanumab, we have to do the clinical trial to find out if it actually works.
Right. No, I like that. And I like the idea of being able to give, obviously, the positive. We can go, with MS, it can be negative. Our thoughts can, plague us with negativity. So I think, standing on the positive, and if there are things that are coming out, that are in study, that we can focus on that it is inflammatory, and that we can slow that down, I think is really important, that we focus on that, rather than, okay, I was diagnosed, now I'm in primary, now I'm in secondary, there's no hope now. Because I know what you've seen, it's got to be close to what I've seen. I've seen some incredible breakthroughs with my secondary. I was going to call them patients, but I'm not a doctor. I just forgot for a minute. But with my clients, and I'm like, you're doing amazing. And I hope that you see that. And sometimes there can be just such deep depression with that, and without seeing the positive things that are happening.
Yeah, and by the way, I didn't mean to be pessimistic. Even if it is something like mitochondrial failure or some other form of degeneration, there may be, other potential treatments that would treat that aspect of it, just not, these Bruton's tyrosine kinase inhibitors. Maybe that someone with progressive MS needs like 3 different things plus lifestyle. Maybe they have to have a healthy diet, exercise, plus take something to block the smoldering inflammation, and maybe in the future some neuroprotective agent as well.
Now, what are your thoughts as far as, I've heard a lot in the last year, 2 years, about reaching a certain age, and then we've kind of touched on this a little bit, but then getting off all medications because they are slowing down. They are not needing something as strong as Tysabri or Ocrevus or maybe anything anymore. What are your thoughts on that?
Well, this is a very, very controversial issue.
I know, that's why I waited to ask you.
If you ask different doctors, you will get different responses, of course. So the theory here is that, one, as you get older, the risk of taking any medication may increase, particularly immunosuppressant medications. The other is that the sort of natural history of MS is that there may be less inflammation as people get older. People just naturally make less new lesions and have less relapses. They may have progression, but it may not be as driven by the type of inflammation we're targeting with these drugs. So weighing the risk-benefit ratio, some people would say, maybe you don't need to take medication. Let's say if you're over 60, you haven't had a relapse or a new MRI lesion in many years, or maybe you're taking medication and you're still having some progression. It doesn't really seem to be working for you. Maybe you should cut your losses and reduce your risk. Now, some people would strongly disagree with this. They would say, it's ageist to stop medication in someone just because they're older. After all, some people who are older do still have relapses, and maybe there is still a benefit to take these medication. And, it could be up to you, the risk to benefit ratio. there was actually a study on this, a randomized trial called DISCO MS, where they took people who were a little bit older and they asked them, are you willing to be in the study? You'll be randomized to continue a treatment or to stop the treatment. And there was a slight difference in MRI outcomes, but not a huge difference in clinical outcomes. So I would look at it, it was roughly similar. It is relatively safe to stop medications for someone who's older and has not had recent MRI lesions and relapses. Other people would strongly disagree with that. Personally, what I do feel more strongly about is, when you look at certain drugs like Ocrevus in primary progressive multiple sclerosis, this was actually proven to be effective in a randomized trial called the Oratorio study. However, in that study, the average age of people was in their early 40s, and many of those people did have gadolinium-enhancing lesions, and they excluded people over age 55. And the benefit of the medication was relatively modest. I believe it was a 21% reduction in disability progression compared to placebo. So it wasn't a home run. It was modestly effective, and it certainly has risks of weakening the immune system. Now, let's say someone is 65 and they haven't had an active lesion or relapse in many years. Maybe they've had recent infection. I think the benefit of that medication versus the risk is very dubious in certain situations and certainly not evidence-based. And in my clinical experience, I've seen many people get burned badly. So if it's your ambition to take like a powerful immunosuppressant, really think carefully about that if you're someone who would be higher risk of getting infections.
Sure. Absolutely. No, that makes sense to me. I know that I've seen that as well, that people in their 60s, 70s, still on something like that, end up in the hospital with just a really bad infection. So yeah, I would say, so if you've got a patient 65, 70, and they're coming to you with secondary progressive, your first thing would not be to put them on.
It depends. I mean, I can't give like an algorithm. If someone was 65 and they're newly diagnosed and they're rapidly getting worse and they have, active lesions, I think it's very reasonable. I mean, obviously there's no evidence for it, but, it's something to consider. I'm talking about someone who hasn't really had signs of active inflammation, has had the disease for many years, maybe has had progression despite taking these medications. That person may not be the best candidate.
Sure, absolutely. Well, thank you for clarifying that one, because I know that's been a big question. As far as where you are now in California, I already know so many that are going to you. So let's say we've got somebody in a different state that wants to be able to see you. How does that work? Are they able? I get that question so many times, so I can't imagine how many voicemails come to you, because every time, I'm in Michigan, so I get so many questions. Is there a way I'm like, you have to call his office. I don't work with him. I don't. So, is there a way that people can see you if they don't live near you, they live in a different state?
Yeah, unfortunately you can't. I'm not doing this to try to recruit patients. I have a California medical license.
Yes.
And, I work for an HMO called Kaiser Permanente. And
no, you did not ask me to say this.
It would be against my contract to treat patients outside of so unfortunately, I cannot help you personally. If you happen to be a Kaiser member, you can ask your neurologist to refer to me. I'd be happy to give you advice. But generally speaking, I unfortunately can't give you personal advice.
You just have to go move to where Dr. Beaber is. That's your
there are other very qualified neurologists, hopefully close to where you live. Yeah. So I'm not the only one.
Yeah, for sure. And we really always appreciate it. It's always, it's just it's very wonderful to have you on, and your YouTube videos, we've seen them done by different doctors, and you can tell that they just want to be YouTube stars. And we really appreciate when you do yours. And I hear that from just a lot of people, that a lot of MS patients and a lot of people that just really appreciate the stuff that you put out, because it really is extremely helpful. And we may have to listen to it 40 times to understand what you're saying. However, it is it's fun when you do the games. Today was really fun. And we just really appreciate all of the things that you bring to us, that you bring informational to us, especially during the pandemic. Not that it's over yet, but hopefully soon. We really appreciate all of the things that you brought to us when we were stuck in our homes and couldn't leave, and just bringing so many things to us that, that we didn't know a lot of, that we thought we may have known, but didn't really. And those were so important. And, just to have someone in our corner that we can say, this doctor is really fighting for us is a big thing when we have this crazy disease that we don't know if it's going left, right, center. We just don't know what's happening. So it is a big deal. And I want you to know how much so many of us deeply appreciate you.
Well, thank you. I appreciate it. And I enjoy making the videos. And if anyone has a video suggestion, you can post it a comment and I'll take a look at it. I do write them down. I can't say I make every single suggestion into a video, but I may many months later.
That's awesome. I would love for you to do one on the different kinds of exercising. And if running or one of them is too harsh, or I love that, because I have people all the time asking, like, can I do this? Can I bodybuild? Can I do this? Can I go like rock climbing? Can I jump? I'm like, I ask your doctor on that one. So I think that would be kind of funny. So I think, like, can I jump off? I don't know. Can I die? Can I jump off the plane? I'm like, that to me would be a lot of vertigo, but hey, if you want to do that, go for it. So, that's just my personal thing, but, I'm sure you'll have a lot of questions from this, but I do think that you need a cleaning lady in there. I'm just seeing a lot of different bags. And so, no, I'm just kidding, because when I have my, marketing person, she'll look at this, not care about the podcast, and see everything I have out, and then call me and say, you need to clean this up before the next time. So, I'm just teasing you, giving you a hard time. So I deeply appreciate you being on this. And again, I really want my husband to move into California so I can be your patient, but I do really respect you, and thank you again for doing this.
Well, thank you for having me on.
Absolutely. I look forward to your next, whatever you're going to have on next Wednesday. I always do. I always look forward to what is he going to have? What are we going to talk about this Wednesday? So, again, I appreciate it. I appreciate you answering my crazy questions. And I know my listeners will be excited about those, and really look forward to the next time. And so I'm going to say to our listeners, so be with me for a second. So guys, if you've got any questions, again, feel free to email. I'll have a link at the bottom of this podcast on what we talked about and some of the studies. So feel free to take a look, and feel free again to always rate the podcast with a 5.0. Thank you. And go ahead and give me, as well as Dr. Beaber, what you'd like to see for him as far as his YouTube videos. And I don't do YouTube videos. I do YouTube podcasts and YouTube workout things. So always, again, give me those, and don't forget to rate the podcast, and can't wait to see you guys again. Have a great day. Talk to you guys later. Bye-bye.